Hi, my name is An Lee. I'm from the Cleveland Clinic Eye Institute. I'm very happy to be here to share a case with you all. So this is a 73-year-old African-American male who has severe low-tension glaucoma at baseline. He's had SLT before, pressure was 12 to 14, which is controlled on maximum topical generic eye drops, and the Tmax was 16. His baseline vision is 20/25 but has significant glare, so he desires cataract surgery, and that's why he's referred to me for cataract surgery and combined with a glaucoma procedure in hopes of minimizing some of his drops. So upon meeting him, I repeated his OCT RNFL, and you can tell that there's significant inferior RNFL loss, specifically with severe wedge defect that with thinning to the infratemporal rim that's very classic for low-tension glaucoma. But this has been stable compared to even 2019, so it's generally a stable disease. So his visual field from 2019 shows, you can see diffuse center involving loss that corresponds to the RNFL. I didn't repeat another visual field prior to surgery because he has cortical cataract and didn't want that to confound our assessment. You can see there is definitely central loss. But he was stable for low teens eye pressure range. So my decision making is to do a combined phaco with Canaloplasty 360 and goniotomy 180. So in the US, iTrack Vans is on label and FDA approved for canaloplasty as well as goniotomy. So for most of my patients, if they don't have more than the average bleeding risk and can tolerate a little bit longer vision recovery from hyphema, I do generally offer that to just maximize treatment in the angle as much as possible. But in Europe, it's only on label for canaloplasty, so that's what I would officially recommend here. I picked a case that has a little bit of troubleshooting in the beginning for interest of discussion. As you can see, as I am trying to engage the catheter, either not getting the intubation or I'm losing the blinking light right away. And mind you, the patient is very comfortable. He's not giving me the ouch feedback that you might suspect because I'm not creating a big cleft here. And that's something that's very beneficial for the iTrack Vans device, where the blinking light gives you immediate real life sort of guidance and feedback so you can retract and reposition right away. Once you realize that the catheter is kinky and going posterior, you want to immediately retract and reposition. One of the tips is to make sure that your angle of contact with the TM is wider open so you're not having any kinking. And then the second is you can use the Singh hook to create a little landing strip to initiate that engagement. And I also use the OVD Helon cannula to kind of inject directly into that Singh landing strip to create almost a manual viscodilation right at that initiation point to help with that engagement. So normally the iTrack Vans is so ergonomic and very easy to create that intubation of the catheter, but not all TMs are created the same. Some can be a little tough and a little harder to initiate. So if you happen to have a TM like that, these are steps I would recommend on maybe making that initiation a little bit easier. So once the catheter is in, that's the Singh hook there. Just a tiny little manual goniotomy is all you need. And then that's the Helon catheter blowing right into that initial goniotomy. And again, this is a much wider open angle of contact that really made that initiation a lot easier. And as I see the catheter traverse 360 degrees, as I'm retracting is when I'm asking my assistant to really do that carpal tunnel exercise, really quick clicks, 36 altogether, 3 clicks per clock hour. And right before I exit, I'm re-intubating again 180 degrees to do that goniotomy and pushing a little bit with a little bit of resistance so the catheter doesn't retract out. And then that's the 180 goniotomy right there. Post-op outcomes, expected hyphema, but pressure is 16. I start prednisolone every 2 hours to help with the hyphema healing. And restarted latanoprost and CoSapt. And a week later, he was already resolving that hyphema, 20/25, but he had some positional vision changes that he was a little bit concerned about. So we actually talked about the other eye, which was happening 1 week later, and decided to do cataract surgery and the canaloplasty alone without the goniotomy to help assist vision recovery. And he was fine with that, with a great vision right after. But again, pressure 10 with latanoprost CoSapt, and then month 1, vision was 20/20, pressure of 9. The latanoprost and CoSapt, and at this point, this is my latest follow-up. I'm still tapering off the pred, by the way, at this point, still BID, prednisolone, and I'm stopping one more drop because all I'm aiming for is a low teens consistent pressure. and I think it can get there. Yeah, that's my case.
That was great.
Thank you.
No, I think it's a lot of great pearls, by the way, of that. I mean, first of all, you saw surgically how, even though she couldn't get in without having help with the Singh hook, before she was trying to re-angulate. So if you ever feel like the catheter's coming down, kind of re-angulate your cannula upward a little bit there, and then point a little bit more towards the TM. That's the fine balance of all these devices, is trying to find the right angle of approach and how much pressure to put at the level of TM. But a great point, if you're really having a hard time with that, make a little opening and just go dilating that opening so it's a little easier for the catheter to go in. So that was a great troubleshoot. I also think it's fantastic to say, we don't have to always, to get success, it doesn't always have to mean complete reduction of medications. Our goal is to always reduce the med burden if we can. But this is a fantastic result. You have one less med topically, which is a big benefit. Number two, your pressures are down like 4, 5, 6 millimeters of mercury. So I mean, that's a great outcome for an NTG patient like this. So great job.
That's absolutely correct. And for the patient, his motivation is to get rid of his cataract. He knows that his glaucoma is stable, and he's on max drops and 5 drops per eye. So we're able to reduce to possibly 1 drop, and that would be a huge improvement in their quality of life there.
Yeah, and that's something I've realized over the last decade and a half, I'm old now, of doing all these MIGS procedures, is that there is a value to getting rid of just one medication. I think that's something that we don't even appreciate, but now after doing SLT and MIGS, we realize how much of a benefit for the patient it is, so that was a great case as well. Well, that's a fantastic case. Do you have any more things you want to talk about with this case?
No, it's all. Hand out to you.
No, that's awesome. Well done, well done. Well, I'm Paul Singh from the United States in Chicago, not too far from Cleveland, and also glaucoma, anterior segment, do a lot of cataract refractive surgery. And I many years ago kind of drank the Kool-Aid, so to speak, in terms of adopting MIGS. Back in 2010 and 12, some of the earlier MIGS procedures we did, and I think over the last decade and a half, really evolved kind of what my thought process is on really how much can we reopen the conventional pathway. Historically, I always thought that if you're on multiple medications, everything's fibrosed, you really can't open the conventional pathway. You have to do an otomy or you have to do a subconj bypass. But I'm realizing a lot of these patients, especially more mild to moderate patients, even if they have a high pressure on multiple medications, with even canaloplasty alone, without even going otomy, in some patients we can really reopen the entire conventional pathway. And I think one of the misunderstandings that we've had is that canaloplasty doesn't really enhance the entire outflow pathway. There's a thought of, okay, just breaking herniations within the canal, and that's it. What is the actual contribution of the viscoelastic in terms of the TM? Does it really actually open the TM and cause those microfractures? Is it really getting into the episcleral venous system? Are we really opening up the episcleral venous system at all? And so I'm going to show you a case in a video how we really can see just with the viscoelastic how much fluid is going into the episcleral venous system without even doing INA as well. So I'm going to share this case in a second here. Any thoughts so far? Anyone have any questions about her case while we're getting my case?
Yeah, you can open up the angle a little bit more. And one provider at COI who actually uses pilocarpine as a post-operative drop to supplement the original GAT outcomes. The idea is that you can, maintain the TM open a little bit longer. We actually did our own cohort series analysis, and even though the immediate pressure lowering was significant because it is a glaucoma med after all, long term it wasn't as salient of an outcome. But definitely, especially for tough cases where you are worried about maybe the TM collapsing back, and that definitely could be, post-operatively using Pilo or even intraop for better visualization too. Yeah, thank you.
All right, well, that was a great case again. I'm going to share a case. It's a patient who came to me already having a history of a glaucoma, had a history of Tmax in the 40s actually. Was on a combination brimonidine and timolol medication when they came to see me. History of radial keratotomy and pseudophakic patient. No history of any MIGS procedure done. And patient was having some issues after adding the drops from the other provider of fluctuating vision, having some issues with night vision and reading, etc. By the time they came to me, our optometrist in our office added a PGA and a ROCK inhibitor as well. So patient on multiple medications. Pressure did come down and actually performed SLT, and with SLT and all those medications, we were able to get the pressures down into the middle 20s or so. So patient definitely had high pressure. Now if you look at the, this is the surface, and this is what I want to say. I tell you, I've learned the impact of the ocular surface with all these topical glaucoma drops that have benzalkonium chloride and PGAs. Over time, not only will affect the meibomian glands, the goblet cells, but actually will cause trabeculitis, cause actual scarring and fibrosis of the conjunctiva and the episcleral venous system. And when you see this kind of surfaces like that, that's why these patients are vision fluctuating as well. And so here's the OCT. Now, a good thing about the OCT is actually not advanced disease. I mean, the RNFL doesn't look too bad. I mean, there's some potential thinning there superiorly and inferiorly in the left eye. But if you look here, the GCC is not too bad. Right eye has a little bit, or left eye has a little bit of some thinning there, but not too bad. And this is the idea. Some of these patients may have high pressures, but may not have advanced disease. I mean, this is a patient who doesn't have advanced field loss at all, right? Pretty mild to moderate. So this is what I like to think of as the separation of what is our disease severity and what is the resistance severity. Here's a mild POAG patient, not advanced at all, but has high pressures and on multiple medications. So my thought is, our goal target pressure is not 10 or 12. I'll be happy keeping in the upper teens, keeping it stable, trying to reduce the drop burden. I'd be very happy with that. And so for me, it's get the patient off the drops and hopefully stabilize the IOP, but I don't have to be very aggressive in terms of reduction of IOP, but I do need to comprehensively address the entire outflow pathway because the resistance is probably not just TM. It's probably the canal and the distal collector channels as well. And so again, what was our goal for this patient? Like I mentioned earlier, combination of lowering IOP, but that's not the main issue. For me, it's getting them off the meds and keeping hopefully stability as well. Quick recovery. So this guy's an RK patient, pseudophakic, seeing pretty well, wants quick recovery. So that's why my goal was to do something that's minimally invasive, least destruction to the target tissues, with the idea of quick recovery post-operatively and very consistent recovery as well. And so why I decided to also do canaloplasty is it leaves all the other options open. So let's say it doesn't do enough. I can go back and do a goniotomy. I can put some stents in the eye, or I can even do a subconj MIB or subconj trab or tube if I need to. So you leave all the options open later on as well. And I think for me, the risk of hyphema when I do canaloplasty alone tends to be a little bit less. I'm not sure if your thoughts are on that too as well. When you do an otomy, especially people who have, let's say, a high EVP potentially, or have a lot of hyperemia with all these drops, you can see a hyphema. When you have viscoelastic only, tamponading that reflux of blood, these canaloplasty patients tend to not have as much of a hyphema post-operatively. So that was the idea for why I decided to pick canaloplasty with the iTrack. So here's a video of mine. I want to share with you the video. What I'm going to do here is talking about the importance of visco delivery. That's the idea. Canaloplasty with pressurized visco delivery as well. So here I am just making, so my paracentesis here, aiming towards the nasal angle. You see the RK lines there. And I'm going to go ahead and make sure I have a good view here. And I'm going to aim upward and a little bit of some pressure. See how I was going down there? So I'm aiming up again and a little higher, and now it's going in the canal, going all the way around. And it's very efficient with the slide of the actuator. You don't have to do a lot of sliding. It goes around very efficiently as well. But here's what I want to show you in this video, I think is really important, is the amount of blanching that's occurring with just the visco delivery. So we have our technician going click, 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 about 3 or 4 clicks per clock hour. But I want to show you, though, I'm going to zoom out here in a second here, and I want to show you the amount of viscoelastic delivery here. Let's take a look here. So as we get down here, now watch what happens. See all that blanching seen here? The entire episcleral venous system now has turned white. And look at that arrow there. Ready? Watch what happens. I'm going to click right now here, and watch what happens to that blood vessel there. It just starts to disappear. So we're seeing viscoelastic traversing all the way down to here, about 4 to 6 millimeters away from the limbus. That's impressive, and that only happens because the amount of pressure that's going into the canal. So the amount of pressure going into the canal is pushing it through into the episcleral venous system, and some of it's coming back into the anterior chamber because there's only so much volume the canal can handle. So the viscoelastic has to go forward, and it comes back. So you're really comprehensively creating those microfractures of the TM, opening up the canal with a catheter, and then pushing the viscoelastic into the episcleral venous system as well. So that is, to me, one of the benefits of this procedure, is not just breaking the herniations, but really the advancement of the pressurized visco delivery as well. So how did the patient do? Well, post-op day 1, this is real data, I promise you guys, 2025, almost back to baseline, pressure in the middle teens, 16, very little cell and no hyphema. I mean, this is a very quick recovery for a lot of these patients as well. Now it's about a month out now, and you can see here, vision's back to baseline, pressure on no medications is in the middle teens, 17. I am more than happy with that. Even if it goes up to 20, I have found in my career now, it's not just IOP reduction. If I can stabilize the IOP, I'd be happy at 20, 21 with those fields and those nerves, keeping them stable, getting them off the topical medications as well. So any thoughts on that case?
That's a great case, Paul. I really think that was a perfect patient selection. So even though he had a very high eye pressure, so it was early on disease, you think there's still a lot of that plasticity and the natural drain for you to maximize by doing distal collector channel dilation. So I think that was a great patient selection. And obviously, immediate, excellent outcomes here.
Yeah, and that's the thing. Patient selection is really key because that's going to dictate what your expectations are. If you have a patient who's more moderate to severe glaucoma and your target pressure is, let's say, low teens, then you're probably going to have to expect they're going to be back on a med or two, and you may want to combine it with a little bit of an otomy or like a maybe 90 degree or 180 degree otomy. But in someone who's more mild like this, the goal was just to reduce the drop burden, get the pressure down a little bit lower, and if I had to put him back on 1 drop versus 3 meds or 4 meds, I think he would be still happy as well. So that's kind of why I chose only canaloplasty. I want to share with you, because this is the same patient I did his other eye, because both eyes had high IOP as well. So his left eye also did very well, and about a week later now, this is recently, his pressure was on 20 off of medication. So again, I'm more than happy with that, and so I had a video for this patient as well. Similar idea though, you see significant blanching, really 360, and what's key is not just at the limbus, but also about 4 to 6 millimeters behind the limbus, which I thought was really impressive. How many clicks are you clicking in your canaloplasty cases on average?
We're asking 1 clock hour, 3 clicks, 1 clock hour. So 36 altogether.
And about 4.5, I think, microliters of viscoelastic per click on average. So you're looking at
a lot.
You're looking at about 12 or so, 30, 10 to 12 microliters of viscoelastic per clock hour. That's a significant amount. There's a concern that people have though, but what about causing a decimase, detachment, or tear? What do you say to that, and what have you done if that happens?
No, that's a great question. With that amount of volume and delivering, I haven't seen any issues. And I do the other concern, obviously, decimase tear. The other concern is maybe even aqueous misdirection. It can also be directed posteriorly, right? Mm-hmm. And I do a fair number of narrow angle cases, so combined with the phaco, and they have no issues. I think the fact that we're injecting as we're retracting is a key to that. So even though it's pressurized, it's a kind of controlled pressurization. It's not kind of there's no we're actually opening space up as we're delivering. So that's one thing I would recommend, is that do the visco injection while you're retracting rather than when you're advancing where there's extra pressure if you do it that way. So I haven't seen any issues. I've been very happy with that.
Yeah, that's a really good point. I think the key is we have a pressurized eye. So as long as you have a good pressurized eye, use a viscoelastic, that's going to give you a tamponade. Your anterior chamber is pushing back at you. And as long as you're continuously moving that catheter, it's okay to do 3 or 4 clicks per clock hour. I have not seen that happen. The only time I've ever seen it happen is if you're not moving and you're clicking, but you're staying in one spot, then it could cause a detachment of a decimase. If that happens though, nothing to worry about. You can bubble it or just leave it alone. It'll naturally resorb on its own if it happens. So that's been something I haven't seen very much at all. Another pearl for hyphema. Any thoughts on, if you do get a hyphema with any of these procedures, whether it's goniotomy or I was going to say canaloplasty or stenting, any pearls to help with potential risk of hyphemas?
That's a great point. I think one thing is that when you're having that chair time with a patient, if you're planning on doing goniotomy or something that has a high risk of universal hyphema, I tell them, I prep them, and this is actually what I'm expecting to see. If I see hyphema, it means that actually I was able to reach my endpoint. I'm able to open up that TM, and it's blood reflux. It's not necessarily a reflection of tissue trauma, right? So if pressure is low intracamerally, then blood is going to return into the AC, so it's a sign of success, anatomical success surgically. So I prep them, and then they realize it's a price to pay, so to speak, kind of an immediate slow vision recovery, but eventually it will lead to better outcomes. But intraoperatively, ways I employ to minimize hyphema is really tank up that eye a little bit higher, sometimes leaving that viscoelastic intentionally, maybe 20-30% at the end of the case. I do phaco first and then do the mix procedure afterwards. So I put in extra viscoelastic and then the end remove maybe even 70-80%. Where you can just tank it up with a BSS and then palpably leave the eye intentionally higher, high 20s, so that they can kind of tamponade that initial bleeding. Yeah,
great pearls.
Expectations, I think, is very important when you're doing
managing the expectation as well as huge. And then intraoperatively, you made a good point. Pressurize the eye. One thing I've learned too, along with that, is you pressurize the eye, but try not to let the eye decompress at all. So when you're going with your INA, let's say doing phaco, etc., you have your INA in there and you're removing all the viscoelastic, and then what happens? We come out, the eye flattens or chamber flattens, and then you put your BSS. But by that time, you've caused a whole kind of migration of heme into the anterior chamber that way. So what I like to do now as well is, before I come out, I'll kind of stop the irrigation, but leave my INA tip there, take my second instrument with my paracentesis, fill up the eye as I'm coming out, so you don't let that collapse as much. That way it doesn't allow that gush of heme. Number two is, when you have a high pressure, let's say at the end, keeping it pressurized, let's say the 30s even, I'll slowly decompress it, not to physiologic IOP, but slowly decompress it to a high level. So I'll start really high, Tap it, wait for about 10, 20 seconds. Tap it again, wait for 20 seconds. What I want to do is slowly decompress it and then leave it high, because that allows that tamponade, allows the equilibration rather between the anterior chamber and the episcleral venous system as well. So that's kind of helped overall as well, but great points there as well. Last thing before we end, what are your thoughts of, let's say you can't get all the way around. Let's say there's some stricture. Everyone's anatomy is different. Anyone have it where it didn't go all the way around for some reason? Yeah. Yeah. So talk about that. What do you do if it stops, let's say halfway through? What can you do?
Yeah, I think you can either recannulate backhanded. It's a little bit awkward that way, but you can certainly train yourself to do that. So small pupil there, it's like you operate with very small pupils. So that's one way, or sometimes it's okay if it's not complete, and then you just say you maximize, you did the most you can. And I might tag along goniotomy at that point, just to treat the angles you can access. Or maybe even go back to the original gap where you can manually treat the remaining little angle there, backhand maybe. Or maybe switch your scope and your chair to the other side. So you're almost approaching the patient through your nose bridge, and then access it again through a different point and see if you're able to traverse that point of stricture there.
Yeah, that's a really good point. Going backhand, the beautiful thing about this tip is you can twist the tip any direction. So you can go any way, left or right, however you feel comfortable. The other thing which is kind of nice about it, as mentioned, having visco delivery is, let's say you get a stricture, you can back up, do a couple clicks on the way forward actually, and on the way forward that can open up the canal, break some of those herniations or the strictures, and then you can go around that stricture as well. So it gives you the flexibility to go and push viscoelastic on the way forward or on the way back, and I think that's kind of the nice flexibility.
That's a great point.
That's a nice flexible thing, yeah. So I've had that happen a couple times, because everyone's anatomy is different, no matter how much we try, and there's going to be situations that happen. Lastly is, let's say you only get 200 degrees, 240 degrees. That's also okay. I mean, you think about how much we're treating, even 180 degrees, I've had significant responses with 180 canaloplasty. So it doesn't mean that you're not going to have a response if you don't get 360. So I always say, if you don't feel comfortable doing backhand or having to push through it, leave it alone. You're going to get most likely still a good response as well. Any thoughts, any comments from anybody here in the audience about what we presented? I do about 3 to 4 clicks per clock hour, and so 4 times 12, I would say, around that, 50 to 60 clicks
36
probably.
to 48.
Yeah, probably 50 or so is what I go for.
36 to 48 altogether. I usually, again, if at some points, as you say, there's a little bit of stricture and you're not sliding as quickly, then I tell my system to pause. Otherwise, you can focally inject a little bit too much. But it's a very smooth slide, so it advances and retracts very, very efficiently, very fast. So you almost have to make sure the assistant really keeps up with you to deliver that frequent and high volume. But yeah, 3 to 4.
And the idea is that I have learned to not be afraid of delivering more viscoelastic than less. At first, I was 1 click and then 1 click and I would stop, but then I realized it's very rare to have a negative outcome by doing 3 or 4 clicks, about 48 plus for 360. And that's going to give you a good amount of viscoelastic in there as well, so yeah. It depends on severity. Because my target for that patient, that one I just presented, was a little bit on the higher side, 18, 20, I'd be happy with upper teens. My goal was more to reduce the drop burden safely. So in that patient, I was okay to stop the drops and then add if I need to. Now, if I had a more moderate patient, more severe patient where I'm a little worried about that patient, I would probably keep them on at least the aqueous suppressants and then slowly take them off depending on how they're doing as well. So that's kind of the nuance, the comfort level. It's not a bad idea if you say, hey, let me keep them on the meds and then take them off slowly. That's another alternative as well. For me, he was just suffering so much with his surface and the eye was red. You saw how red the eye was. So I just wanted to get him off the meds. And I felt safe because he had such mild disease. I felt like I had that opportunity. This patient was less than a year, probably 6 months. That's it, yeah. Patient was not, again, had a history of RK, had a history of cataract surgery, so that patient was small pupil because it was an aortic pseudophakic standalone case. But these patients, a lot of times, you add a drop with a BAK, a PGA that irritates the meibomian glands, you kick them over the edge. They may not be very symptomatic, but you add that one topical drop and all of a sudden you kick them over the edge. And so that patient was suffering very quickly because that patient came to our office soon after the optometrist outside OD, saw the patient, put him on that combination drop, saw our ROD, they put him on a PGA and rho kinase inhibitor. I did SLT to see what that would do, all within like 6 months. Absolutely. And what I would do though, if I had to repeat, I probably would do a goniotomy at the same time. So anytime I've had to go back in again for any reason, then I'll do a goniotomy and say, look, you know what, let me just be, just hedge my bets a little bit there and remove that TM or cut some of the TM. So, but you can. Good friends of mine, Mark Gallardo and Mahmoud Kiami in the United States, they've done a lot of studies, and there's a whole subset of patients that they followed over a few years actually with the repeat canaloplasty and showing significant efficacy as well. It depends. Of course, to be fair, every glaucoma is different, so we'll see how this patient does. I've had data now for years. Again, there's published data, again, Mark Gallardo and others, 3 years data showing significant efficacy even at the 3-year mark. Do we have anything more than 3 years? 6 now, right? 6. Yeah, so 6-year, Kerber has 6-year mark. So there's a good chance, the reason why I think we see that longevity, there's a question mark of really, are we truly helping the outflow enough to completely open it up? Maybe, maybe not, but I do think if you open the canal and you open the TM enough, you then reestablish flow, that natural flow keeps it open long term. And there's, in my opinion, this is just my personal opinion, hyaluronic acid has some anti-fibrotic components to it, in my opinion. I think it does prevent further collapse. Again, more data is necessary. This is not something that I can show you data for, but in my theoretical thought process, I do think that hyaluronic acid serves as a way of decreasing the further collapse over time. With trabeculotomies and goniotomies, I tend to see more of the potential 1 week, 2 week, 3 week pressure spikes than I do with canaloplasty. Do you feel that way too sometimes?
Right. I think if you're combining goniotomy, there's multiple factors contributing to early spike, like a hyphema, but sometimes patients don't experience that. Yeah, or steroids, that would be more like 1 month or a little bit later, right? Time course wise. And one thing I think you want to be cautious of, if you have a very early spike, say in the 5-day to maybe 2 week range, you might have maybe inadvertently created a little cleft, a small one that then self-healed. You can have that rebound spike that's higher than baseline. And most of the time, again, with the iTrack Advance, you know if that's happened. And I'm a little bit more cautious of those patients that created just a little bit of initial cleft maybe, but because the feedback is so immediate, I don't create a big cleft. Whereas maybe some competitive devices, you're relying on patient's discomfort to almost tell you that you've made the wrong path. So generally it's not a very big cleft, but if you do, that may be a reason for a very high pressure spike in the 1 to 2 week period. But those patients generally can recover because it's not, lack of function, it's more like the function of the TM is a little stunned. So you want to bring back the drops to let them have that time to recover, and generally you don't necessarily have worse outcome later on. It just takes a little bit longer to get there. So I would say those are kind of the reasons for spikes. Obviously the steroid response comes later, and then hyphema being another cause. But yeah, those are generally transient.
Yeah, the heme in the collector system, like clots, I think can be a reason why the pressure spikes, absolutely. I think it's important to recognize too, though, that a lot of times we are reopening up the conventional pathway, and it can take a while for it to reopen, so we stop the drops sometimes right away, right, and then all of a sudden within a week, the pressures are like going back up again too, so there's a lot of variability, but I do agree that we don't see a significant issue, especially with canaloplasty, with pressure spikes. They usually are self-limiting, and they can be controlled pretty well with topical meds. Yeah, good point. I guess for that, thank you so much for letting us be part of your day. I want to thank you, my partner here as well. Awesome. Thank you.